On record. Good morning. Welcome to MED110 Anatomy Physiology 1. This is now week 7, February 16, 2021, 9 a.m. And what is due today? Let's get this screen up and running. I was with my internet this morning. What is due today, of course, since it's week 7. So what is due today? Task 6, discussion 6, lesson 6. And what are we doing this week? We are doing respiratory function. And if you look at your task for next week, we've been looking at the structures of the respiratory system, where and how we do respiratory gas exchange, the exchange between oxygen and carbon dioxide, and a little bit reminder on how and where it gets transported. There's also a nice little video here on what is actually respiration. This is a dead video, so don't try to click on when you see things like this. So let us go to chapter 22, respiratory system, in our textbook. Click on that. Is open stacks, table of contents, all the way down to chapter 22. Okay. Now, when you look at this, this is your respiratory system. Its main function is to take in oxygen and let go of carbon dioxide. And from the oxygen from the atmosphere and carbon dioxide from our bodies, utilizing the oxygen as fuel, and the carbon dioxide is our waste. If you see here, there are two sections. You have the upper respiratory that starts from the trachea and everything on up. So your nose, your nasal cavity, nostrils, of course, also known as your nares, N-A-R-E-S, opening here. And of course, your oral cavity, because you also breathe through your mouth as well. And your throat, which is your pharynx, and your larynx, which is your voice box right here. Those are all upper respiratory tract structures. Now, if you have an infection of your upper respiratory tract, that's a URTI, that's upper respiratory tract infection. So if you have pharyngitis, laryngitis, pharyngitis, that's like sore throat. Laryngitis, you got a little, little infection where you can't talk. Your voice is hoarse. Rhinitis, which is nasal cavity, and also we have holes up here in our skull called sinuses, right? And you could also have sinusitis, and that is also it goes all connected up here to the upper respiratory. Now, from the trachea on down, that's lower respiratory. And from the trachea on down, which the trachea is your windpipe, that's where it starts getting dangerous. So anything from your any infection from your trachea on down, that's your lower respiratory tract. That includes all the pathologies like bronchitis, emphysema, chronic obstructive pulmonary disease, pneumonia. All of those things are really bad, and they're here in the lower respiratory tract. And just like what we talked about before, anything deeper in your body is more delicate. Anything deeper in your body is way more important. And if you could see where the location of the lungs are, they're behind ribs, they're behind a lot of muscle in your thoracic cavity. So it's well protected because it is one of the primary things that keeps you alive. Now, you have what they call a conducting zone and a dead zone. Now, the conducting zone, or the lower respiratory, deep into the lower respiratory tract, because that's where oxygen and carbon dioxide get exchanged. And that's the part that we're really, really concerned about. All these other parts, like the trachea and all this other tubing, that doesn't contribute to gas exchange. So you'll hear words like dead zone, because up here air just goes through here. But this is just as important, even though they call it a dead zone, right? This is just as important because if anything blocks anything up here, we all know that having a cold and other things, we all know how difficult it is to breathe, especially if these passageways are blocked. Okay. If you look at the nose, it's covered with cartilage. Okay. You also have these openings called your nares, Nares, right? And this is part of it's a continuation of your nasal bone, and then it goes into all this cartilage up here. And it makes sense because the nose can't be a rigid thing. It has to be something that will keep these holes open, but not be as so rigid that it can't expand and contract when you're breathing, but not too much. You also have a septum, or your nasal septum. It's the little piece of cartilage here in the middle that separates the left and right nares. You also have these, they're called nasal conchae, and like a conchae, like a shelf. So these are like shelves. Think of them as shelves. And the entire respiratory tract is covered in mucus. And we all know that mucus is our innate immune system, that because we're breathing all this garbage and all this stuff, dust and foreign body, bacteria, viruses, and mycoses, it'll trap it all in here, right? That's why it's good, blow out your nose. And remember we mentioned the sinuses, little holes. They're little closed off rooms that are inside our skull to not only make our skull lighter, but also they also project sound. That's why your voice sounds so well when you listen to yourself talk. After the nasal area, it now will continue to your pharynx. Here's your oropharynx, because this is your oral cavity. And you could see this is all connected. That's why when you start laughing and you're drinking milk, it might come up here and, spill out of your nose. You can also notice here, this is the cribriform plate right here of your ethmoid, and your brain is right here. And there are nerves that pass through here that that facilitate, your sense of smell. This is also the reason why people, snort drugs. If you snort like cocaine or heroin in here, it's gonna latch onto these nerve endings here and then go directly into your brain. Problem is, like things like cocaine, that powder is quite abrasive to the turbinates and all these openings, this meatus, and it starts wearing away at this ethmoid plate. Not a good thing. When you go further down, of course, this is your tongue and some muscle. Helps push the food, right? Oral cavity. You also have your throat. And here in your throat, oropharynx coming to your laryngopharynx. How do I know? Because there's cartilage here. And that's how you know you're in the area of your, what do you call that? Your voice box, your larynx. Now, within there, and you can see your larynx here, it has vocal folds. And that's why your voice gets funny if you have pharyngitis. If this gets all gummed up with infection and inflammation, and the vocal folds won't vibrate efficiently, and then your voice will significantly change. You'll also notice here, there's this flap of skin that's called your epiglottis. Now, here in the anterior portion, you have cartilage here, and that's your trachea or your windpipe. The tubing, the muscular tubing that is in the posterior section of your throat here, that is your esophagus or your food pipe. So when you are eating, this flap goes down, covers this area, so that food will go straight down the esophagus. You don't want food going down into your lungs. Your lungs, in all intents and purposes, because don't need dirty food. And you could, if any food or vomitus gets into the lungs, that's not a good thing, because then you'll have something called aspirational pneumonia, and that's very hard to get rid of. You could see the respiratory epithelium is full of cilia, which is also part of our innate immune system. Pseudostratified columnar epithelia with goblet cells, and the goblet cells produce mucus. So the mucus has a lining here, and the cilia moves that that mucosal lining with all that dust and foreign object, and even viruses get caught up in here because it's so gummy. And then that's why when you cough or when you sneeze, and that again is part of innate. You have your hard palate up here, soft palate here. So you could see how in this area here of your oropharynx going into your laryngopharynx, and your pharynx, of course, is your throat. You could see how if this gets any excess mucus or any inflammation in this area, that's not a good thing. And it'll start blocking the passageways. And again, here you have your trachea. How do I know? It's anterior, and I have cartilaginous C-shaped rings that go here in the front. But your if your esophagus, your food tube, it's a very flat tube, and it only expands when food goes down it. And that's why when you're eating or drinking, this epiglottis has to go down. So all intents and purposes, you are kind of holding your breath when you eat or drink. That's why you shouldn't talk when you eat or drink, or you're going to confuse the epiglottis and you'll start choking. Here's your larynx, and here's your laryngeal. There's a bunch of cartilage that makes up your larynx or your voice box. Of course, it tops off here with the epiglottis. Here's another view of the C-shaped cartilaginous rings, and it's C-shaped because remember there's a tube in back of the trachea, and that's your esophagus, and that has to be able to expand. So if you had trachea all around it, you won't be able to expand your esophagus. That's why the trachea is only on the sides and the front, and the cartilage only forms C-shaped cartilaginous rings, and that's your trachea. Here's some vocal folds. So when you're speaking, the more air you rush through it, the louder it gets, and the less air, the softer it gets. Okay, and you could easily see if there's cancer or damage here, it will significantly affect your ability to speak. Now, you look at the trachea. Starts right here, right at the bottom of your larynx and all that thyroid cartilage. And little by little, the trachea, it'll split in this place called the carina, C-A-R-I-N-A. That's the crossroads of your right and left bronchus. If you'll notice the right bronchus, or right mainstem bronchus, your primary bronchi, it's shorter and fatter on the right side. This is the right side, the right lung. Remember, we're looking at our patient. So foreign body, like if a kid swallows a marble or something, not only swallows a marble, but gets a marble somehow, and it's amazing what goes down here in pediatrics. It'll most likely fall here on the right side. That means the right side will have a greater disposition for foreign body. And you'll notice little by little, once the bronchus starts getting smaller and smaller and smaller, it loses this this cartilage. And once it gets to the rest of the lung, it loses cartilage, but it gains smooth muscle. Okay? And now we're getting into the respiratory zone, also known as the conducting zone. If you see here at the end of the small bronchioles, right, at the very end, it's called the terminal bronchiole, and then it attaches to, hold up, I gotta get this. Hello, Dr. Garais? Yes? Yes. Yes. Okay, thank you. All right, bye. I hate when the school calls just to make sure my kid isn't dead. All right, so terminal bronchiole all the way at the end, and you'll see it has a lot of smooth muscle. Okay, and that controls, you know, the lumen or the diameter of these bronchioles. Now, if you at the very end, they have these sacs of, and they look like grapes, hence the term alveoli. Now, your alveoli in, I forgot Latin or whatever language medical terminology is, it's usually Latin with a touch of Greek. Well, these bunches of grapes, in these bunches of grapes, that's where you're going to have capillaries, when you see here, where there's going to be gas exchange. There's going to be oxygen coming in, going into these arterioles, and there's going to be carbon dioxide coming from these venules and then going into the lungs so it can go out. So the alveolar sac is the location of these capillaries where there is gas exchange. Hence the term, the respiratory zone, also known as the conduction zone. Everything else is just tubing and space. Hence everything else is called dead zone or non-conducting zone. So again, to recap, terminal bronchiole, as the, if you notice here, the lung, the bronchi get smaller and smaller and smaller, like a tree. When it gets to the very end, at these end of these branches, there's these bunches of grapes called alveoli. That's where gas exchange occurs, and that's where you have tons of vasculature, okay? And the reason why the alveoli are really neat and they keep themselves open is because they have these alveolar cells that release certain chemicals. And one of the main important chemicals is pulmonary surfactant. Surfactant it keeps the surface tension so that you see all this alveoli, it keeps it all open so that gas can go in and out. And you could see also the alveoli are just like the capillaries, they're thin one cell wall so that it's easy for oxygen and carbon dioxide to go in and out. Another thing that alveoli have tons of are macrophages, because remember, the air is a dirty, dirty place. We always mention that there's 250 things that could kill you up there, and if it gets past the innate immune system, we need things like these macrophages to go kill whatever's left floating around in here. So you got macrophages, you have alveolar cells, and the type 2 are specific to make this stuff called surfactant. That's why when a newborn or a premature baby, when one of the fears that we have in pediatrics and neonatology is that if a baby is born too early, they don't have enough surfactant and they can't breathe very well because the surface tension won't keep these things open, okay? And surface tension is, if you've ever seen water, it's like the water's ability to bead up and to form a little dome, and that's what's happening here in your alveoli. And you could see they're chock full of blood vessels. You can see here from this diagram, capillaries, and they're chock full of spaces. So you can see here how your lungs have to be moist because gas is going in and out of here. Your lungs can't be dry, nor can they be wet. So there has to be homeostasis. There has to be somewhere in the middle. So let's look at something like asthma. What will asthma do? It'll increase this mucus, okay? Now, what asthma really is the asthma's patient, it's an abnormal immune response. So here's an example. Like if some dust kicked up in my face, you know, I'll maybe cough a little bit, maybe sneeze, okay? But if some dust kicked up in an asthmatic's face, that asthmatic patient will have a much more sensitive immune reaction. It will increase its mucus, it will increase its inflammation, and it will then increase a whole bunch of white blood cells, and then you'll have greater inflammation. Another thing that will happen with the asthmatics, Asthmatic patient is, see all this smooth muscle, it's going to start to squeeze because it's a signal to your lungs that, hey, there is some foreign body, there's something going on, but it'll be exaggerated. And this mucus will then make the bronchioles, the lumen, all clogged up. So hence, it'll be harder to breathe. And for several asthmatics, it's not always, that's when they start having this wheezing, okay? So difficulty breathing, of course, lower respiratory tract infection, increased mucus, increased mast cell production, because that's indication of inflammation. And that's why we have to treat them with corticosteroids to decrease the inflammatory, mucolytics, right, to get rid of this layer. But it's better to attack the mast cells, because I'm not a fan of mucolytics getting rid of the mucosal lining, because the mucosal lining, all intents and purposes, it's an immune function. I don't want to. I'm already decreasing your immune function with the corticosteroids. So let's look at external structures. Of course, you see the trachea, and this is the right lung. This is your left lung. You'll notice your left lung only has two lobes. You have an upper lobe and a lower lobe. And it has a cardiac notch because this is where your heart would sit, because your heart sits more towards the left side of your thoracic cage. Now, your right lung has a superior lobe, middle lobe, and inferior lobe. Now, you may ask yourself, okay, because what's the purpose for the different parts? Well, it's really neat that, let's say I get cancer here, your lung will try to keep that cancer only in that lobe. So it's partitioned off as a safety or a protective function. Okay. Blood supply. Let's look at. Are they gonna talk about it? We'll look at the next diagram, and then I'll come back to it. Another thing the lungs have is they're an enclosed system. Okay, so that enclosed system is going to create certain pressure gradients, which we're going to talk about in a moment. And one of the ways we can create that pressure gradient, right, to keep the lungs open, is a covering. And the covering of your lungs is called your pleura. Your pleura has a visceral layer and a parietal layer. The parietal layer is the outside layer. The visceral layer is the inside layer. And in between is the pleural cavity that has fluid in it. You can't have too much fluid, or it will do what? It'll compress on this lung, and that's not a good thing. You can't have any openings, or the pressure will get all messed up, and then the lung will collapse. A great way to know how that's done, all you need to do is stab somebody in the chest. It'll poke a hole, it will release all the pressure, and then the lung will collapse. It's never a good thing. Another thing here about the pleural cavity is that, you know, when you get a really bad cough, this can also fill up with pus. That's not a good thing either. You'll get something called pleurisy. Pleurisy is when the pleural cavity gets infection, and then you get pleuritis. It starts rubbing against the bones, especially here on your manubrium sterni. And so when you start coughing, it feels like a knife. And then it'll make your breathing even harder than it was. So pleuritis is a serious thing, because right next to pleuritis, once you have an inflammation and infection of the covering of your lung, you can easily get the inflammation and infection of your lung itself. There are also muscles involved in the muscles of breathing. One set is your intercostal muscles. We'll talk about that. And another is your diaphragm right here, which is a thin strap muscle that demarcates your thoracic cage here from your abdominal area down here. And we'll talk about how those muscles also create a pressure gradient so you can breathe. Because remember, if you remember diffusion, gas acts just like any other particle. Gas moves from a pressure gradient of high to low, right? And your muscles, these two sets, intercostal and your diaphragm, create that pressure. I'm trying to find the inside of the lung. Oh no, they're going to go right to it. Let's look at think I either skipped it or uh, lung external anatomy. That's close. Here you go. Now, this area right here is the connection that goes into your lungs. Now, what important structures that enter and leave your lungs? Of course, you have your main stem bronchus, right? Which is right here. Then you have these things colored red and blue. Red, of course, is your pulmonary vein, and your blue is your pulmonary artery. Now, remember from the cardiac lecture, it's backwards, right? The oxygenated is the vein, and the deoxygenated is the artery for the pulmonary circulation. If you remember your heart, the box diagram and the video, and if you haven't watched it, please watch it. So if the lungs ever get separated or damaged here at this section, what messes it up? You could have leak of blood and leak of air, right? And also here, of course, there's a lot of dirty things that go in and out of your lungs. It makes sense that there are lymph nodes. This is a beautiful all of the above question, and this is a common question that gets asked. What are the structures that go in and out of the lung? But just remember, the pulmonary circulation is backwards. So this colored red, and of course in real life that's not colored yellow, blue, or red. You have your pulmonary vein and your pulmonary artery. Your pulmonary artery is deoxygenated. Your pulmonary vein is oxygenated. Also, another thing that the other diagram didn't show is we had, of course, you have your left upper lobe, left lower lobe, but there's a line of demarcation here, a little border, and that's called a fissure, right? Little indentation here, and that's the oblique fissure on the left lung, which separates the left upper lobe from the left lower lobe. Now, you have an oblique fissure as well on the right lung, but you have three partitions here, or three rooms, or three lobes. You have the horizontal fissure in between the right upper lobe and the right middle lobe, and then you have your oblique fissure between the right middle lobe and the right lower lobe. The way I remember it is that both of them have obliques. This one has a horizontal, and this only has two lobes because the left side has a heart notch somewhere in here, right? And then the right side, 1, 2, 3, horizontal lobe and oblique fissure. Okay. Anything else? Nope. So how do we breathe? Well, we breathe because of pressures. And what we know from Boyle's law, that means if you increase the volume, right, the pressure decreases. It makes sense. You have all these air molecules, they're bouncing around. If I give them more room to bounce around, everything gets more relaxed, right? So the pressure in this chamber, since the volume is increased, right, the pressure will decrease. But as a volume decreases, if I press down on something, what will happen? The pressure will increase. So that shows that pressure and volume are inverse of each other, meaning when pressure increases, the volume has to decrease. When pressure decreases, the volume has to increase. So they're kind of opposites of each other. So knowing that, how do I breathe? Well, it's because of pressures, okay? So you don't have to memorize these numbers, but just know that when you're, let's draw a diagram. I think that'll be That'll be a little easier to do. So let's draw something. So this is your lungs. And then you have your main stem bronchus. Here's your carina, and then going up your trachea. Now, when you have inhalation, right? When you're inhaling, okay, that's inhale. Let's pick another. Can I pick another color? Should be able to pick another color. Sure. When you inhale, of course, air from the outside world comes in. Now, how does that do that? Remember we talked about pressure gradients? Outside, the pressure is positive. Positive atmospheric pressure. Okay? Now, how do we make the positive go in? Well, the lungs have to be less than positive, because remember, you have to go from a positive to or a higher pressure to a lower pressure. So remember the diaphragm that was here? The diaphragm will start bottoming out. And remember the intercostal muscles up here? That'll move the chest up and out. Now, what will that do to our lungs? Remember we talked about the pressure, right? I'm expanding everything. So goes, if I expand the volume, what am I doing? I'm making the greater the volume, the lesser the pressure. Therefore, I'm creating a negative pressure. So that's positive pressure outside the atmosphere. Let's write this whole word pressure. And if you have a positive pressure outside, your atmospheric pressure, and then your intercostal muscles go up and out, and your diaphragm down here goes down, it creates a negative pressure. Kind of the same way, you know, when you pull up on a syringe, what happens? The fluid goes inside because outside pressure is positive, the inside pressure is negative, so all the fluid starts going up. So that's what happens when you inhale. What the fudge? I'm sorry, this is my son's school. Good morning, Dr. Garais. Yes? Okay. Okay, we'll monitor it. Okay. Okay. All right, thank you. Wow. All right, I'm sorry for that interruption. So to recap, what happens when you inhale? Your diaphragm, contracts and pulls the lungs down. Your intercostal spaces moves your chest cavity up and out. And that will create greater volume. Greater volume will drop the pressure to the point where it's negative. And then the positive outside pressure is greater than the negative inside pressure of your lungs. So now it goes just like diffusion. It goes from, oh, you got to be, never mind. Then the positive pressure then goes to the negative, right? Because this is greater than this. So then you inhale. Now, when you exhale, right? When you get to the point where you can't inhale any longer, you can't you can't increase the volume, pressure will start to build in the lungs. And when you exhale, the pressure inside the lungs will be greater than atmospheric pressure. And then you exhale. And then the exact opposite must happen. Your intercostal muscles will relax, and so will your diaphragm, because you can't hold your breath forever. It'll create a greater positive pressure and then go out. Now, what happens, remember we mentioned the covering, the pleura, and remember you want to mess up this gradient, right? All you have to do is poke a hole right in here. Foreign body, what they call missile injury or a gunshot, or you stab somebody, boop. What will happen? There's nothing holding up this lung, right? There's no pressure gradient, so then the lung will collapse. So that's not a good thing. So what kind of questions could come out on a typical exam regarding the pressure gradients? This is a classic NCLEX question. They'll give like a positive pressure out here, like 760 millimeters of mercury, or 1 atmosphere, also known as I forgot how many torr, 760, forgot. But there'll be a big positive number out here, and there'll be a much, much smaller number here. And we now know that what? Big number, little number, has to inhale. It goes, if the pressure on the outside and the inside are equal, like let's say, for example, I put a hole in here, or my patient is dead, is my patient breathing? Nope. And there's no air exchange. Okay. It goes, and if the pressure here, the positive pressure is greater than the positive pressure on the outside, then my patient will exhale. Okay. So those are the pressure gradients, and it's based on Boyle's law. So that is a really nice thing to know, especially for you future nurses and going into NCLEX, and you'll eventually have to start memorizing these numbers. And 760 millimeters of mercury. Millimeters of mercury is typical pressure of 1 atmosphere, or if you're at sea level and hanging out outside. So don't have to memorize numbers for my exam, but you gotta have the concept of what happens when you inhale and what happens when you exhale. And when you inhale, diaphragm goes down, the intercostal muscles move your chest cavity up and out, increases the volume, decreases the pressure to a negative pressure. So you have positive atmospheric pressure to a negative pulmonary pressure. So now the air will go in. Now at the very height of pressure, right? What will eventually have to happen? The diaphragm will relax, your chest wall goes back to normal, and then you exhale. And we have to inhale so I can take in the oxygen, right? I have to exhale so I can get rid of the carbon dioxide. Now, here's a nice thing, nice to know for my exam, but for future NCLEX, must know. Must know what all of these volumes mean, and you will eventually have to memorize all these numbers. But for now, all you need to know is this. Of course, we have a pulmonary function test, PFT, also known as spirometry, okay? And you have another test, which is your ABG, which is arterial blood gas, okay? So when you're looking at arterial blood gas, measures 3 things. Of course, the gases, the amount of oxygen, amount of carbon dioxide, and of course, the pH, or the acidity or the alkalinity of blood, which is important in how the blood either keeps or lets go of oxygen and carbon dioxide. Now, these lung volumes here, right, they all measure something, and you could see how it's like Lego, how they're all put together. So you have your inspiratory capacity. Now, tidal volume is what you do when you're typically quiet breathing. Then you have everything else. Your inspiratory reserve volume. That's what's left in your lung if you do forced inspiration. So tidal volume plus IRV, which is inspiratory reserve volume, equals inspiratory capacity. Now, what's functional residual capacity? That's your expiratory reserve volume. That's after you breathe out everything that you can breathe out. Then you got about 1 liter more space left, and that's your residual volume. So that's called your functional residual capacity, which is your ERV plus your RV. So you can see how these two Lego pieces equals this. These two Lego pieces equal this. These three Lego pieces, ERV, TV, and your IRV, equals vital capacity. Vital capacity is, of course, vital, what you require for your lungs to live. And of course, vital capacity, and then what you have left over, that's your residual volume. And total lung capacity is what? Everything, IRV plus TV plus ERV plus RV, or inspiratory capacity plus functional residual capacity, or your FRC. Now, all these volumes get measured through a machine called a spirometer, okay? And for my exam, just know what a spirometer is, spirometry, and know if I ask, what's your normal breathing volume? That's your tidal volume. Just know this is the basic definitions of what this is. I won't ask you to do the math. But for future, this is a classic NCLEX/MCAT question. If you're taking the medical college aptitude test or your NCLEX, they always ask you about like volumes. They'll ask like, oh, if there's a 1 liter increase in decrease of IRV, which of the following capacities would be affected? A, inspiratory, B, vital, and it'll be like that. But for me, I would ask, what's the volume of your typical quiet breathing? Tidal volume. What's left after it goes, what is the volume of me forcibly breathing out, or breathing out as much as I can in my lungs? That's expiratory reserve volume. What's the amount of air that I can when I inhale, right? On top of my tidal volume, that's my inspiratory reserve volume. And then whatever's left is, of course, your residual, also known as your residual volume. And they all have this. They have all these abbreviations. So keep it simple for my exam, but for future reference, really in your best interest to start looking at this chart and this chart, start memorizing it. Respiratory rate, okay? Of course, respiratory rate, it depends on, of course, your sympathetic and parasympathetic nervous systems, right? If you're in danger, like fight or flight, of course, your respiratory is going to increase. And if you're in parasympathetic, it will decrease. And typically, it's 12 to 20 for an adult, and a little bit well, actually much faster for babies and children. Okay, which is labeled down here, but you need to know the adult. 12 to 20 is good. Greater than 20, tachypnea. Less than 12, that's bradypnea. Now, what controls all of this? If you look at, it's at the base of the brain, at the level of the pons. You have your VRG, DRG, which is your ventral respiratory group, and your dorsal respiratory group. These are all nerves that are all bunched together that deal with your intercostal muscles and your diaphragm. Now, so VRG, DRG, PRG, they are located here. It goes at the base of your brain, and that makes sense. You have your entire calvarium or your entire skull to protect this. So even if you shoot yourself in the head or get shot in the back of the head, I'm very gruesome today, you could still live. You still can breathe, because your pons and medulla is still controlling your intercostal muscles, right? Now, what happens when you have a hard time breathing? You start using your accessory muscles, like your shoulders and your chest muscles. Those are accessory respiratory muscles. That's how also you can pick up on some physical signs and symptoms of dyspnea or difficulty breathing. It's when my patient's hunched over and they're starting to use other muscles other than their intercostals and their diaphragm, okay? That's all controlled by ventral, dorsal, and pontine respiratory groups, your VRG, DRG, and PRG. Now, Your medulla, of course, here, right? Oops, pointing at the wrong thing. Here, controls rate, okay? So basal skull fracture, fevers, anything bad that can get into down there is not a good thing. Another thing that your system also looks after is, remember I mentioned arterial blood gas, partial pressure of carbon dioxide, partial pressures of oxygen, and the pH, okay? That's the aortic and carotid bodies. These are nervous system monitors, right? Now, what's the next thing I have to talk about? So even though I can blow out here your capacity to think and to remember things and even to talk, which is this area right here, you still can breathe and you can still keep on going. So whoever built us, remember what I always said, whatever is the deepest inside your body, it's the most delicate and really important. Gas exchange. Now, if you look at oxygen, not a lot, about 21% in atmosphere, right? And there's also water vapor as well. Now, it is not the measurement of oxygen in your body that dictates you breathing. It's the measurement of carbon dioxide in your cerebral spinal fluid. That's the thing that your body monitors, the amount of carbon dioxide. And that's what dictates how fast or how slow you breathe. And of course, that's the area of the medulla. And again, more oxygen, increase in pressure. More, what's a lot in our atmosphere is mostly nitrogen. But remember, too much of a good thing becomes a bad thing. If I drastically increase the oxygen in the room, we'd be blind by the end of the hour because oxygen is highly reactive. Now, when we use the word respiration, respiration just simply means the exchange of oxygen and carbon dioxide. So we already seen different levels. We already seen it at the organ level where the lungs and the atmosphere trade oxygen and carbon dioxide. We now see here, right here at the cellular level, also known as cellular respiration, between the carbon dioxide and oxygen. And we need to get rid of the carbon dioxide because that is a waste product. And we already know what we need the oxygen for. We need the oxygen combined with glucose to make ATP. So the oxygen has to get in as well. And you could see between the alveoli and this, the blood here, it's only one cell thick. So it's easy to go in and out. And it makes sense. If I'm exerting myself, if I'm living, I have a lot of carbon dioxide, and then all the carbon dioxide should go where? Out, because it's an area of high concentration to an area of low concentration. And if I don't have enough oxygen in my internal system, there's more oxygen on the outside, so the oxygen will then go in by the laws of diffusion from high gradient to low gradient. Oxygen transport. How does oxygen and carbon dioxide move around? Well, you should be familiar with this molecule right here. You can even see it has seats. This looks like, to me, this looks like, you know, you took somebody's lawn chair and just totally twisted it up to make it look like, I don't know, like modern art or something. But you could see here, this is a heme group, right? Made out of iron. And what sits on these four seats, 1, 2, 3, 4, is oxygen, carbon dioxide, and other things like glucose. And the this molecule is hemoglobin. It is what is in the empty middle part of your red blood cell. Here's your red blood cell, classic biconcave disc configuration with no nucleus. But it doesn't have a nucleus, but it has a hemoglobin or a heme protein, and heme because it's blood, and also they have these iron, these little iron discs here, right? Which change the conformation and have things sit on it. So you have oxyhemoglobin. That's how you know in arterial blood that the hemoglobin is carrying a lot of oxygen. And then you have carboxyhemoglobin, which carries carbon dioxide, and the all too famous hemoglobin A1C, which is glycosylated hemoglobin, which carries glucose. That's why you should not lie to your physician about your diet. I just give it up. I just tell them exactly like, hey, I've been eating Doritos for 20 days straight. I just give it up because it's going to come out in my A1C. And your glycosylated hemoglobin or hemoglobin A1C tells the status of who is sitting on this hemoglobin for the last 90 days. And if it's above a 6 or above 5.8, like mine is, that's not good. You're in the diabetic range in that area. Hemoglobin, dissolved carbon dioxide, yada, yada, yada. Breathing too fast, hypernia, right? Altitude effects, nice to know. Because, you know, the air is thinner when you go higher up a mountain. That's why if any of you ever did hiking or ever went to some place like Rocky Mountains, I remember the first time I ever went snowboarding in Colorado, the mountain is much, much higher. I felt like I was going to vomit and pass out on top of the mountain. It took me like a day or two to get acclimatized and to get my hemoglobin acclimatized to the thinner air. And by thin air, we mean less pressure of oxygen. Here's developmental of lungs. It's not. So let's now go back to see if we hit up all our points. So let's look at our points I read. Did we talk about the structure of the respiratory system and all its players? Yes, we did. Respiratory gas exchange with the alveoli. Yep, we did. Oxygen and carbon dioxide transport to and from the cells in the lungs. Yes, it's via diffusion. And why do we need the oxygen? And you could look at this video. It's for ATP, and that's called cellular respiration. And respiratory respiration is between the lungs and the outside world. So it looks like we got everything. All right. With that being said, you could easily make up a concept map. Well, not easily, but straightforward. No such thing as easy, right? And then how all of these link together. Let's look at also what's due next week. Let's look at this discussion. Now, discussions talking about technology and telehealth. Okay. It goes, now this is big. So you should be able to get an article from 2021 easy. Because telehealth, because of COVID has now totally eclipsed regular office visits. I don't know. It's a pretty neat thing. So that's. I thought they would talk about something in lungs, but I guess that's the topic for this week, and it's a pretty good topic. So you should be able to find something from 2021. Remember, when talking about technology, a year or two ago, and also, I don't know if this was the class that also had stuff about technology. I think it is for the musculoskeletal. Just know that a lot of the stuff that the lay people get, once they get the news of it, it's 9 times out of 10 is usually 10 years old plus. So that's why it's even more pertinent to get the most available data. Also, another thing I noticed about a third of you guys pick the first thing you see. So about a third of you have almost the same post. For future stuff like graduate school, and also definitely for those of you going into nursing, try to pick something that other people won't pick. Don't stick to the first page of your Google. Dig a little deeper. And for those of you who have comments on your discussions, look at those comments, because even though I give you a full score, you really should dig deeper. Now, all of this stuff, don't ignore all of this stuff, remember, right? What should you be looking at? The case, the mystery of the 7 deaths. So let's click on that. Download case. So let's look at, how many pages? This is pretty good. Do all of them. It's pretty good. It's pretty quick. So do all questions for the mystery of the 7 deaths, right? And of course, Microsoft Word document, please. And that's about it. That's due next week. It's at this portion of the show. I will